should stand up there. You think so?
I am amazed at how many bodies are in these seats. Thank you for being here. This is very exciting. Congratulations to you. 12:30 on Friday. This is fantastic. I am Jeff SIegelman from Emory, and together with Drs. Rotoli and Mirus, we're going to chat over the next 19 and some minutes around how best to incorporate interpreters into your clinical care. I have unrelated research support from Equitable, which is a company that's maybe more relevant to the prior conversation around color blindness. But today we're focusing on really the impact of language barriers on care for linguistic minority populations and how best to utilize medical interpreters in the clinical space. And so we'll take this next 20 minutes to go through some background and some cases and best practices with you. Before we dive in, maybe to set the stage a little bit, I'd love to get your thoughts on some struggles that you all have had with caring for patients who cannot converse in spoken English. And so if you wouldn't mind jumping on the poll everywhere there, we can take just a moment to share some brief thoughts, and I'll read them out for you. Just go ahead and type away. So one person speaks some increased difficulty building rapport, and then it takes time. It takes using an interpreter, or and that's certainly for sure. This is really a weird way to see this. So people speaking to time, difficulty communicating. And that they're under triaged, which is certainly something that we deal with. So as over the next 15 minutes, we'll try and take some of these thoughts into as we approach some best practices for taking care of these patients.
I just want to add, I appreciate the honesty in some of these responses. They are anonymous, which always helps, but I think that all of us feel that that burden of not enough time with the patients that we have, and now we have to take an extra step and involve one or two or three other people to try to add that on. And I think that it's okay that it feels like a burden, because I think that helps you recognize that you may already have a bias going into that encounter, and then it helps you prepare a little bit better for that encounter.
Hi, I'm Dr. Mars. So a little bit like, why are interpreters important? And it's really comes back to effective communication, right? And effective communication not only helps you identify what the patient is there for, helps you achieve the diagnosis, but even from a medical legal sense, communication is key. So you're not only protecting your patient, but you're protecting your own practice as well. There's been numerous studies that show that when you have interpreters involved in care, that patients report feeling like they can build a rapport, feel like their satisfaction levels are high. And that's imperative, right? And I think it's so, that word cloud is interesting. The biggest word that was put up is difficult. And I, as a former interpreter myself, I would agree. It was an adjustment for my own practice to have to go from seeing English speakers to where I work now at Parkland, where about 40 to 50% of my patients are Spanish speaking. And that was a difficult adjustment for me. And so I think difficult is a very appropriate word, but if you take a look from the patient's point of view, that interpreter is the only way they can access the world around them. And that's why the interpreters are important. There's also customs, nuances, cultural aspects that unless you're part of that culture, you're not going to understand or fully appreciate. And interpreters can help bridge that as well. So who can be an interpreter? There is not a standardized interpreting catch-all for everyone, and different languages have different certifications, and even in states are pretty different. But let's talk a little bit about ad hoc interpreting, and this is kind of interpreting on the fly. We do a lot of things on the fly in the emergency department, And a lot of the times, we may not have an interpreter readily available. The VRI, video relay interpreting, or the iPad, the Wi-Fi is not connecting, or there's not an interpreter showing up because the language you need is so difficult to attain an interpreter at 3 in the morning. And you have a family member there. And you're going to use a family member over not using anyone, right? But there are, there's significant considerations that need to be thought about. For example, when you're using a family member to interpret, you're really taking away the patient's ability to speak for themselves, because the family member may be dismissive of the patient's complaints because maybe the patient has complained about this all the time. The family member doesn't think this is a big deal, and that's going to come through when the family member's interpreting. Or you could have the complete opposite happen, where the family member may be exaggerating or adding on symptoms that the patient's not really feeling. You're not getting a true interpretation of what the patient is saying. You're getting a filtered message going through the family member, and that's when you start mixing advocacy, patient advocacy, and interpretation. And those are two very distinct things. And so it is very difficult for someone to be a patient advocate while being objective to interpret. It's very difficult to do. And sometimes it's necessary, but as long as you're thoughtful and mindful of this, it can be done. But types of interpretation, there's in person, where the interpreter is actually at the bedside. There's video interpretation, so that's called VRI, so video relay interpretation, and a lot of us use iPads for that. And then there's telephonic, which is a telephone landline type of interpretation where someone's on the phone. All of these types of interpretations do qualify to meet a standard of if you're needing an ASL interpreter to meet the ADA law or Americans with Disabilities Act that require that interpreters be present at medical facilities or medical encounters. All of these do meet that standard. However, there are significant nuances about video interpreting and telephonic interpreting, which we'll kind of go through a little bit later. When at all possible, getting an in-person interpreter is by far the best choice. It is the gold standard, and we'll touch on that in just a second.
So I'm Jason Rotoli. I'm from University of Rochester. I'd like to give you guys an example of a patient interaction. And I'm going to play a video here in a second. And in the interaction, I'd love for you guys to focus on whether I am using medical language or not, the speed and the cadence with which I talk with the help of an interpreter, my engagement of the patient, and also my positioning. And I might ask you if I did well or not well afterwards.
Okay, so I have all of his test results. Can you just tell him that his CAT scan and his labs were all normal? And I think he just has a little bit of inflammation.
Thank you for letting me know.
Oh. Inside of his abdomen, and he probably can just take Tylenol or Motrin Q6 hours.
He's saying that he'd like you to just direct your talking to him instead of to the interpreter.
Oh, okay.
So I'm curious, from anybody in the audience, maybe who has not seen this video before, I know a couple of you may have, what were your thoughts on my interaction with the patient? Feel free to raise your hand. We'll bring the mic right over to you.
Yeah, so you did a good job. It was directing it all towards the interpreter, so you could tell that there was something off. Like you, instead of talking directly to the patient, you were just talking to the interpreter. And then there was a couple times, instead of waiting for the interpretation to occur and to kind of hear what the patient's saying back to you, you just kind of kind of railroaded over them or spoke over them, trying to get whatever your agenda was, which is something that I think we all have probably been in that place before. We're like just trying to get in and out of the room, just trying to update the patient real quick about something. So those are kind of two things I noticed.
Very good. Thank you very much.
Those are 100% correct. Luckily, these are my friends and colleagues in this video, and some of this actually was organic. I didn't even mean to cut her off while she was interpreting, but I did accidentally, so I left it in there, but you're exactly right. I did not adjust my speed. I didn't wait for the interpreter to finish saying what the patient was saying. I didn't even actually notice the patient was trying to communicate with me because I was directing all of my attention and my language to the interpreter. And I do think that there is a time to engage the interpreter. They are a member of the team, but most of your speech and most of your attention really should be to the patient. The caveat to that is if you're trying to assess for language fluency or dysarthria or encephalopathy, then you can pull the interpreter aside and ask them kind of what their thoughts are about that. But otherwise, all your attention should be toward the patient, absolutely. And again, really trying to engage that person. And the last thing I'll touch on briefly is just positioning, which is a good segue into our next slide, which is really the bulk of our talk. But positioning with the interpreter and the patient is going to be incredibly important. In our ED, where I am right now, the space is so unbelievably limited that it's really hard to make sure that everyone has visual and audio access to the interpreter and to the patient. But trying to set up the best access possible is going to be your gold standard. And I would just ask the patient and the interpreter, what is the best way that we can communicate clearly? Because they are going to be the experts in that situation, and they will let you know. The next thing when working with an interpreter and a patient is to really address your patient in the first person. So I did not do that at all during the video, but asking the person, and how do you feel today, and what can I do for you, as opposed to can you ask him, what's going on. Same thing when you're delivering information back to the patient, their test results or whatever, your CT scan shows. Pausing, I touched on a little bit, but really trying to adjust the speed and the cadence of your speech and what you're delivering. This becomes particularly important in the deaf community, where there is not necessarily a word-for-word translation for everything. So there may be a sign for heart attack, but there is a lot of explanation and visual imagery that has to happen with the interpreter so that they can really make sure the patient is understanding what that term means. So allowing the interpreter to catch up before you move on is going to be really important. And also allowing the patient to interrupt and ask a question or make a comment is necessary. I think assessing for understanding is something that we can do with all of our patients. It is not only the patients who do not use the same language as you or I do in the encounter, but really phrasing it with, what can I explain better to you? What questions do you have? As opposed to, do you understand everything, or do you have any questions? I think if you take the burden off of them and say, what can I do better? It allows the patient to feel a little bit more comfortable in trying to ask those questions. Sort of setting expectations and prepping for the encounter is going to be really helpful. It will help with planning for things like speed and cadence. It will help with planning for adequate positioning. Sometimes you're going to go into a situation where it's really sensitive information that's going to need to be discussed, and that can help the interpreter kind of set the stage and just be ready for that conversation. Some special considerations, Dr. Myers talked about using family as an ad hoc interpreter. I think in the ED we have to do what we have to do. So if you have nobody else, of course you're going to use a family member. But in addition to maybe minimizing or maximizing a certain complaint or a problem that the patient may have, I think there is also the concern for medical language fluency. Obviously the patient and their family member have an established language and they're more than fluent, but you'll often be faced with a 16-year-old interpreting for a parent, and you really need to make sure that that person knows how to translate or interpret the medical words that you're saying. And most of the time they don't. And I struggle with that sometimes, because you want to engage the family and you want to make sure that they're involved, but at the same time I need to make sure what I'm saying is coming across appropriately and that what you're saying is also coming across appropriately. So keep that in mind. VRI I'll leave for Dr. Myers to chat about, but it is a backup. At best, I would say. It is fraught with complications, whether you're using a hearing or a visual language, and you can think about Wi-Fi access and the battery dying, and think about your patient who maybe is bent over vomiting and trying to get that screen down in front of their face, and then think about space in the ED. Like, it's just impossible. There are a couple of pitfalls that we'd like you guys to try to remember and avoid. The first thing is using English idioms. So, I'll give an example. To beat a dead horse, and we all know what that means, but to translate that into American Sign Language, you wouldn't really say like beat a dead horse. Like that is, it wouldn't mean anything. And so speaking plainly and directly is a much better way to get your point across. Avoiding complex sentences or asking multiple questions at the same time, which I think we all do, right? Are you having any nausea, vomiting, diarrhea, or anything like that? Well, that's like 4 questions that now you just ask the interpreter to interpret for the patient. Certainly making assumptions is applicable to any of our patients. Really try to get a sense of their educational level, their health literacy level, and try to match that. And the last thing, which I really hope is not happening, but trying not to infantilize your patient. Use an adult voice. If you're speaking to an adult, use adult terminology while avoiding, complex medical terminology. And the last thing I'll talk about is, how do you get good at this? How do you become proficient? And the short answer is that you really just have to do it, but you can practice it, and that's what I would really try to emphasize. In our residency, we had simulation. We would train some standardized patients to come in and have the residents do an H&P on them, and then the standardized patients are usually from the target community that we're working with, so from the Hispanic community or the deaf community, and then they're the ones to provide the feedback. So it was a great simulation exercise. You can use case-based role-playing with, amongst yourselves, and then really trying to engage in a conversation with your interpreter services, who again are going to be the experts in this, to set up some time to do some education for you and your colleagues.
One of the things that that Dr. Rotoli here is mentioning is prepping the interpreter, and I can tell you as an interpreter how helpful that is. So before you walk into the room saying, "Hey, we're going to go see a patient, belly pain, female 40s, male 20s, whatever," giving that context, or like, "Hey, I'm about to break some bad news, just a heads up." Giving that context is so valuable for the interpreter because they can already start prepping specific terminology, words, adjectives that they're going to use. They're going to change their demeanor, their mood to meet the nature of the conversation that's about to be had. If they don't know what they're walking into, that's when a lot of problems they're already doing things on the fly, right? Interpreters are phenomenal multitaskers. So information is literally coming in one ear. They're switching it into a different subject or a different language, and it's coming out in a completely different language simultaneously, right? So minimizing the cognitive burden by prepping them is so helpful. We'll talk a little bit about ASL interpreters since that's much more of my background. Using the whole terminology, but deaf and having a deaf identity. The deaf community, deaf culture is really founded on the language of ASL. And so we don't want to assume that just because someone is not able to hear that maybe they know ASL or maybe they don't. So again, you want to find out what their language preferences are. Maybe they're fluent in English as their primary language. They just need some other kind of accommodations and not necessarily an ASL interpreter. Education level is huge, and again, this goes back to why you don't want to use family members, because if you have a 16-year-old interpreting, then you have a 16-year-old educational level being that you're giving that 16-year-old being interpreted, giving to whatever their parents' educational level is too, whereas an interpreter can match the dichotomy between a physician and the patient themselves. And so it's just another pitfall to take out of the equation by not using family interpreters. So that way you can match the educational level. And I mean, that's the same as like in discharge paperwork, right? We don't type, you have cholecystitis, you don't throw all these medical terminologies in. We try to match what the patient can understand. Positioning, so this diagram is actually, I think, a great way, and this applies to spoken interpretation as well. You want to have the interpreter by your side, so the patient can see you and the interpreter at the same time. If you split with the interpreter, and the patient's just laying in the bed, and they're going to be talking to you, but making eye contact with the interpreter, and they can't see how you're reacting, they can't, they're not getting any visual cues from you. So this applies to ASL interpretation, to spoken interpretation. Have the interpreter at your side, or go to the side of the interpreter, so that the patient can communicate with you and the interpreter as one team, almost as one individual, and that facilitates communication well. And then that falls into eye contact and body language, right? Significant amounts of messaging, communication, language is done through nonverbal cues. And again, if positioning isn't established well, so the interpreter is on the other side of the room, the patient doesn't have the benefit of catching all these nonverbal cues as well. And then cultural impact on information sharing. This is kind of specific to the deaf community in the sense that when news is being delivered or a story is being delivered, it's usually the main point is the very first comment, right? So if you're going to break something like you have a mask, maybe in a hearing patient, you may say, you may kind of work up like, hey, all your blood work looks good. How are you feeling right now? Do you feel nauseous? Does the medication help? Okay, I'd like to talk to you about your chest x-ray findings. If you did that in ASL, the patient would get so lost in terms of like, okay, what is the point of this conversation? So that's when the interpreter can kind of play into the cultural impact of communication, listen, take in this message and be like, you have a tumor on your chest x-ray, everything else looked okay, and then that facilitates your intent and your messaging through a cultural barrier, right? And the case or in-person interpreter. So this is a kind of like a hot topic in the field of interpreting. This goes for spoken language, ASL. VRI, from a business standpoint, it makes sense, right? In-person interpreters are expensive. VRI is cheap, it's convenient, and you can have interpreters on demand like that. So there are huge benefits to it. However, it is the most difficult form of interpreting there is. I can tell you as someone who used to interpret behind the iPad, it is so hard. So much in fact that you have to have years of experience typically to even interpret in VRI in the community setting before you even go into VRI. But the issue is you have zero context about what you're about to interpret. So you're thrown into a room, who knows if you can even see, you may be facing a wall, but all you hear are people talking. And you get messages like, well, does it hurt still? What is it? What is it? Does hurt? Who's talking to who? Is that a patient talking to another patient, or a family member? Is that the doctor? Is that the nurse? Like, you have no context whatsoever, and that forces the interpreter to be very direct in what they interpret. So they will interpret things very literally because they have no context and can't do it otherwise. And so things like idioms will be interpreted very literally. So they will interpret, if you say, oh, we don't need to beat a dead horse, we've covered that already. They will literally interpret that because they don't have the context to fall back on to appropriately interpret the message. Again, it's convenient. We got to do what we got to do in the emergency department, and I get it. But I've spoken to the National Association for the Deaf has a huge stance on this, and they really advocate for in-person interpreting, especially with ASL. It is a 3D visual language, and so you're putting it on a 2D screen, which really minimizes the ability to communicate. But I've spoken to my Spanish-speaking and interpreting colleagues, and they are just as passionate about this as I am. They realize that being in the room, there's such a more of a connection and communication with the patient, with the provider. Cues can be taken on, right? If the patient starts getting worked up and angry, the interpreter can match the affect and the mood of the provider to try to calm the patient down, right? A video relay interpreter cannot do any of that. So there's so many benefits to in-person interpreting. And so really trying to study the value of in-person interpreting, I think, will kind of offset the cost of interpreters, right? I think there's so much benefit to be had that it is a good investment, and we do need in-person interpreting. Yeah, so that's pretty much it, guys. We're happy to answer any questions, but again, thank you for coming. I hope you guys had a great week at SAEM. Thanks for coming on a Friday afternoon.
Appreciate your time.
For the gentleman that's had interpreter experience. I'm I'm sure many times I've fallen into those traps and made snafus in terms of idioms or, poor eye contact or other things like that. I'm sure I've made those mistakes, but I can definitely say in my career that I've never received any feedback from an interpreter on things I could have done better or mistakes that I made. And so I'm curious if in your experience, did you feel empowered to give that feedback? And also, what are the things I could do better to elicit that feedback to improve my practice?
When I worked as an interpreter, I did a lot of healthcare because I was in pre-med and med school, and that's what I wanted to do. I think there's a power dynamic. I'm not going to tell the doctor how they need to interact with the patient because I'm just the interpreter. I'm just there to facilitate communication. But I would strongly recommend maybe after a patient encounter as a physician or provider to just touch base with the interpreter and be like, how did that go? I do that a lot in terms of patients with encephalitis, right? Or they're altered. After the encounter, I'll go to the interpreter, how do they seem to you? Are they a little bit off? Or I'll talk about with interpreters after a patient encounter if there's been some kind of family dispute. So this happens a lot, right? You have a patient and a family member, and they're just having a 20-minute conversation and arguing about something, and you're just kind of standing in the corner. You have no idea what's going on. That's when I'll pull the interpreter and be like, okay, what's the synopsis of this argument so I can catch up, right? But I think the other thing is I catch interpreters a lot of times using third-person language, right? So standardizing interpreters I think is important to make sure they know what they're doing as well. But I think asking interpreters, hey, how do you think we could have done this differently? Especially if the patient seems frustrated with communication, right? Because if the patient's frustrated with communication, nothing else really, the whole patient encounter is going to be a moot point, and they're not going to be happy with the care that they received.
I'll just add, Dr. Mirus had mentioned the cognitive burden or load that the interpreters are bearing during that encounter. They are doing things simultaneously. They're acting as an advocate. They're acting as a cultural and a language mediator. And so it might actually be challenging in that setting to ask for feedback. If you have an interpreting department, it would probably make more sense to try and get some formal education, but I know resources vary. But trying to do it outside of the clinical environment might even be better for them. It might also help to remove that power dynamic. One more.
I was wondering, oh gosh, my voice. In terms of the equitable care being delivered, is there any work or research kind of looking at differences with VRI and in-person interpretation? And also, is there any work or investigation kind of looking at that in terms of how much experience a certain interpreter has and how that might impact care for a patient? Do you guys know of anything like that?
I don't know if there are head-to-head studies looking at outcomes. There are definitely qualitative studies with patients demonstrating the same theme. Certainly in the deaf community, that in person is just better, and that's where we got a lot of our pitfalls from, is that data itself.
Yeah, there's tons of qualitative research saying that patients prefer it. They significantly prefer it. In terms of outcomes, it would be interesting to see, how, doing kind of a trust scale, or how did the patient feel like they establish rapport, and seeing if there's any differences between an in-person or VRI interpreter, right? Because again, from the patient's point of view, that interpreter is their window to the rest of to anyone in that room, in the hospital, right? And if that person's in an iPad, they're probably not going to feel as well advocated for, right? And that's what the qualitative research has shown.
To answer your question about the experience part, I think that is one of the real big plugs for in-person interpreters. Typically, if you are working with an agency that knows that this is a hospital facility, you have a relationship with them, they're going to send somebody who has medical experience. Certainly in our institution, we have 40 or 50 staff interpreters, so we know that they have the qualifications to be there. When on the other hand, if you're using a phone interpreter or a VRI person, you really have no idea what their qualifications are. You've never worked with them before. I had this happen to me the other day where the Spanish interpreter didn't know the word for wheezing. And fortunately, my resident did and was able to convey that. But I was like, wow, this person is probably not qualified to be in this situation.
All right, I think
Well,
that's
thank you.
time.
Appreciate
you, guys.
it.